Okay, so when I have put this presentation together, I work in a unit where we have different levels of expertise. I have residents, I have fellows, I have newly graduate sonographers and very experienced sonographers. And what I try to do, this is connected. This is how we did it early today. It is connected. Okay, then. But how do I? Let's see. That's mine. No, that's mine. Okay. So let me put this. Okay. So as I was saying, there are different levels of expertise, and I try to select all the cases where we have stopped and questioned the diagnosis. My disclosures have not changed since this morning, so what I hope to cover during the next 30 minutes is first understanding the limitations of cardiac imaging, understanding the reasons why you may get a false negative diagnosis and how you may get a false positive diagnosis. Now, in all the cases except one, I'm going to show that we were able to figure it out. But in one case, I hope you all can pick out and maybe spare us because it was completely missed. And I love this quote from Einstein, a person who never made a mistake, never tried anything new. And so as Rabia said, we learn. With every single case that you question, you have to see how can you walk through it and really confirm whether in the end it was true or not. So what are we doing wrong? In this day and age, when we have all the technology, all the guidelines, why do we still have such suboptimal detection rates? And this was a very nice editorial back in 2016 from DeVore and Sklansky, who highlighted two main things. The first is the knowledge. If we do not have the prior knowledge, whether it is the normal anatomy or what abnormalities look like, we're going to have false positive and negative diagnoses. And second is optimization. If I don't have the optimal settings on my image, I'm going to miss key diagnoses. And this was a more recent article from Palladini and his group. Though it was for the first trimester, it is highly applicable because they talk about our technical limitations, human factors where it's there and we really don't see it, and finally, acoustic windows. And I practice in a setting with very high BMI. You will be able to tell from the cases I'm going to show, the quality of the images is different than this morning's because these could not be the selected normals. Those are the true abnormalities we've had. Remember the size of the heart. So the size at 12 weeks is that of a rice grain, and that's why I do have a rice grain there. And then when we are at 20 weeks, yes, it is the size of a euro coin, and of course, with the very extensive connections that we talked about this morning. And so it is a very complex organ, tiny organ, and it sets us up for a lot of false diagnoses. So I've divided them into 10 areas that I'm going to cover. Some of it has been covered this morning already and may be repetitious. And one of the very important ones is angle of insonation. So this is a recent case where I have also outreach settings. So a lot of times I may be reading in the outreach where we have different equipment as well. And my sonographer called, she was very concerned. This was a late second trimester about ventricular disproportion, where you see that the right ventricle really looks larger. Could this be a coarct? She had nothing else. But of course, as you get a better angle, a more apical angle, you see that there is symmetry. And so your angle of insonation can impact even how the ventricles appear. Now, this was a first trimester case, and as you look here, you will see that the cardiac axis almost looks at 90 degrees. This was a very high BMI patient, very difficult to see. However, with proper insonation, you see that actually this heart was properly positioned with a normal cardiac axis. And so you realize when you're struggling, because of your acoustic windows, be patient, wait, and make sure. We talked already about shadow dropout, and here this is a clear example. So you can make an erroneous false positive diagnosis. And in this case, the baby will rotate here to help us. You see that you suspect a membranous VSD, but then really there was not. And so again, it is very important to have the angle of inclination. As Professor Carvalho said, you have to sweep up as well, because a lot of times too, you may have a VSD that is inferior also to where you're looking at your four-chamber view, and you may see it as you come up from your abdominal circumference plane upwards. Now, we saw similar cases, override. I think this is the biggest mistake that the overcall we do in our unit, is when you don't have the proper angle, when you're slightly oblique. Professor Marr showed this, where you can get this override. And of course, your color settings play a very big role, because I always say you can create multiple VSDs and you can remove the biggest VSD by adjusting your color settings. But here you can see that with proper inclination, proper color settings, there really is no VSD. And this was a very recent case. One of my junior sonographers in the outreach settings, she was very oblique, and you will see that it looks like she has a VSD, there is an override there, so we brought her to the main site, and just a few hours later, you can see that the angle with which the left outflow tract exits is the correct angle. There is no VSD there, and beautiful color settings as well. So be very mindful of the angle of inclination and your color settings. More on color, again, with the override, here you can see that as you are coming from your fourth chamber out to the three-vessel trachea view, you can almost see an overriding aorta there. But of course, if you adjust your color gain, your wall motion filter, your PRF, you will see that there is absolutely no override. So whenever you see something, scrutinize the quality of your image, your color settings, to be absolutely sure. And here's another case where it really looked like there was a VSD, again, with adjusting your color gain, wall motion, PRF, balance, you will see that there is no VSD. Now, this is another case where using regular color, as I looked at it, my eyes wandered to two structures. Right over here, remember at our 3VT, we should have 3 vessels, and then it almost seemed like there is an additional vessel here. You can see the hypoechogenic area. But of course, the color settings were prohibitive, and so by changing now the color settings and using power Doppler, you can see coming into view ARSA very clearly. And so scrutinized grayscale color, if you don't have the proper setting, is not going to show you something without you adjusting really your scales to be able to pick it up. And so this was a case of ARSA with a persistent left superior vena cava. And another, of course, you can create multiple VSDs with the wrong settings and an intact ventricular septum. So now we move to gestational age, and 2 things I would like to highlight with respect to gestational age. The first is the coronary sinus in the first trimester. With the new equipment and the resolution, we have started to notice that the width of the coronary sinus seems to be increased in the first trimester. And we did a recent study on this, and yes, proportionately, the width of the coronary sinus with respect to the atrial width is higher than it is in the second trimester. The ratio we got was about 0.44 versus about 0.2 in the second trimester. So if you see it, do not worry that this is abnormal. Do not worry that this is a sign of intracardiac TAPVR or it's a sign of a persistent left superior vena cava. This is a normal variant. Now we go to things to keep in mind for the third trimester, and that is ventricular disproportion. So it is physiologic to have a larger right ventricle in the third trimester. It is always an alarm. Could this be a coarctation? And so I put both false positives and false negatives there because you don't want to miss coarctation, especially if you feel that this is significant enough and warrants PGE. But at the same time, you don't want every single third trimester physiologic larger right ventricle to be considered a coarctation. Now, area below the heart, what do I mean by that? We do a sweep. on every single fetus, from the stomach actually to the brachiocephalic in our unit. And so the first thing that you're going to see above the stomach before you get to your four-chamber view is your coronary sinus. Be very mindful of that, because if your sweep is slow enough, you're going to see at that level loss of offset and think, do I have an AV canal? Your coronary sinus is going to make it seem as if you have an ASD primum. And so be very careful as well. Remember the area below the heart, that is where your coronary sinus is. And of course, if you have some venous anomaly contributing to a wider coronary sinus, yes, that will be more apparent. Now, this is also another example, sweeping up. You will see here in a second, this is up and down. There's the coronary sinus again, and so be mindful that that is not an ASD. You are below where the AV valves are opening, and that's why you don't see them open and close, and they seem to be linear. Now we go to situs. We talked about this earlier today. So if I just show you this clip and you tell me, I see the stomach and the heart on the same side, you have not stopped to ask what the presentation of this fetus is. It is so easy to miss situs inversus when there are no other abnormalities. And so really this fetus was in fact breech. There was no other abnormality, but this was situs inversus. And so do not, it's very different when you're scanning versus reading. I had to switch from doing all my scans in Lebanon to reading scans, which was a huge shift for me. And so I have to stop and pause and reposition the baby in my mind to reestablish situs. Now, moving to the left ventricle, this is a case where this is at 23 weeks, 4 days. If you look at this, there is some slight ventricular disproportion, but really this was not called, this was considered normal. And it was missed. If you look at the three-vessel trachea view, you will see there is very slight reversal of flow, though your spine is at 9 o'clock. So is it because of the location of the spine or what? And the aortic arch, yes, in hindsight, may be a little bit pinched, but this was read perfectly as normal. And so this is now when she came back at 33 weeks for a growth scan in the third trimester, and you can see really significant ventricular disproportion. This is way more than what you would expect physiologically, and now you can see the reversal of flow into the aorta, and you will see reversal as well on the sagittal views. And this was a coarctation, and you can see the coarct there. Moving to the right ventricle, this was a case read in the outreach setting at 21 weeks. It was suboptimal. She could not get a good apical view. You can see that the right atrium seemed to be a bit enlarged, but it was read as suboptimal, and the patient was brought back. We brought her back to the main site, and this is now 3 weeks later. Here is that case. I showed it earlier today. If you look, you will notice there is a little bit of left axis deviation, but then if you're going to look at the septal leaflet of this tricuspid valve, you will see that it's more apically inserted. Here it is again, and you have an enlarged right atrium. This was a near miss for Epstein's anomaly, and here you can see the regurgitation coming from deep within that right ventricle. So be very careful when you look, and if you see an enlarged right atrium, try to stop and see where these leaflets are. Not all Epstein is very clear. Some of it can be easily diagnosed in the first trimester, and some of it is a lot more subtle, where it may be later on that you pick it up. Next is the area behind the heart, and that is an area that is so important. I hinted that we will talk about this today and tomorrow, especially in the vascular ring presentation. But here, if you look behind the heart, I hope your eyes will wander and see that you have two vessels that are almost the same size. And remember, we spoke that we have the aorta to the left of the spine, and the azagus, which should be about a third of the size. And just from your four-chamber view, seeing this double vessel or kissing vessel sign should immediately alert you to an interrupted IVC with azagus continuation, and then you have to go and try to prove that. And so even though these are very challenging diagnoses to make, just focusing, and as I tell my trainees, always look from the outside in, don't just focus on the four-chamber. That area behind the four-chamber is so important. And here is another case, and you tell me, okay, we're looking behind the heart, and you see two circular structures here. So is this an interrupted IVC with azagus continuation? Well, the difference between this case and the last one is if you see these are not side by side. The second structure is between your left atrium and the aorta. So any takers on what this is? This is knowing your anatomy, and this is the esophagus. So always know that you have the esophagus there, and be mindful that sometimes you can see that it is filled, and do not mistake that for interrupted IVC. It is the location of where it is. And there's the azagus, there's the descending aorta, and the esophagus. And here's another case, you know this by now, that this is also in this matter, this is also the esophagus. Versus this case. So this was a case that came for growth late second, early third trimester. This was not seen on her second trimester scan. And with color, this is sagittally, this did not fill. So this is not a vascular structure. And this certainly is not the esophagus. Any takers on what this is? I think I heard it from the back. It's a bronchogenic cyst. This is incredibly rare. It occurs in about 1 in 50,000 fetuses. So again, this is different from the esophagus. This is different from your azagus. This is usually benign if there's no constriction on the trachea. Now, moving to the area behind the heart, and is there a collecting vessel there or not? We're going to have a full presentation on venous anomalies. But I show this because I'm going to show you 3 cases now back to back. This one, and the missed case, and then another case to show how subtle these can be. And so this was one of my sonographers who came to me that she was concerned, is she seeing a vessel behind the heart? But always remember, and I always say, the heart is not in a dry space. There is fluid around the heart. Depending on your angle of insonation, it is normal to see that. And in the last image on the bottom right, you can see the pulmonary vein coming in very nicely. So this is not a collecting vessel. This is not TAPVR. Now we'll go to the missed case, and I'm going to show you that we scanned this case 4 times. I was the one that read her fetal echo and completely missed TAPVR on it. And even after I knew the diagnosis postnatally, I went back to my images and I still can't pick it out. So we're doing something wrong. This was a very high BMI patient. She was a diabetic. Her first scan with us for dating was at 16 weeks, 2 days. You can see it's not optimal imaging. But some of the signs we look for in hindsight is the distance between your aorta and the left atrium. Because when you have TAPVR, this distance should be increased. You should have a twig sign. Is there a bold left atrium? I'm not so sure I can say. Yes, there must be, because this was total, not partial. But this was her scan at 16 weeks, 2 days, and we dated her. We didn't do anything more. She came back at 19 weeks, 6 days, and here is the scan at 19 weeks. Again, my eyes wonder now in retrospect, is this a collecting vessel, or is this really the pericardial fluid, like the case I just showed you before? And here it is with color. Yes, we did not see pulmonary veins on this scan, but I'll show you her fetal echo here in a second. So this was read as completely normal. Now here it is, the 24-week, 3-day fetal echo. And this is the 4-chamber view, going up to the 3-vessel trachea view, up to the brachiocephalic. You can see aorta is very close to the left atrium. Suboptimal filling, we didn't get much better than that. But then we did think that we got the pulmonary veins there and Doppler them. And we thought that really there is normal venous return to this heart. She came back for growth at 34 weeks, 6 days. Again, look at the proximity of this aorta to the left atrium. Well, I got a call afterwards that review the scan, you missed TAPVR. And my first question was, are you sure it's total or partial? No, it was total anomalous pulmonary venous return. And so we still have a lot to learn. We still have limitations. We need to be mindful of that even when we are following guidelines and trying to do what's expected of us. And this was a case after that one. We became all terrorized in the unit about anything behind area behind the heart. And so there was this sliver here, is this a collecting vessel? Again, this was normal, this was not TAPVR. And so you have to be very careful, and there are some things that I guess maybe will get better with time. Now we move up to the area above the heart. Area above the heart, we heard and we saw beautifully from Professor Marr earlier about the absent thymus. The thymus is so important, going up to your brachiocephalic. But I like to show this case because my sonographer came out to me like, I'm not sure what is going on here. Something looks abnormal. I see the thymus. There is a structure through it. And this is a normal variant. This is an intrathymic brachiocephalic vein. And so normally the brachiocephalic is the posterior border of the thymus, but sometimes it can take a different course and be intrathymic. And the azygos, we heard about it, and Professor Marr showed it beautifully as well. But the azygos can be mistaken for several things. It can be mistaken, as I show in this case. This is not ARSA. Again, there was concern because you see red. You see something coming from where the descending aorta almost is, going upwards. Though we know that ARSA should go straight to the right shoulder, it should not curve and go up to your superior vena cava. So know your anatomy. This is the azygos, and sometimes you can see it very nicely, even if it's not dilated. And this was a first trimester case. As you look at the sweep, you'll see that you will get the branch pulmonary artery coming about here, and then the transverse aortic arch. But they are so small, so close to each other, that they almost look like one line. And then you have the azygos here. Notice it's a different color. But that was mistaken for, could this be a vascular ring? Is this a right-sided aortic arch with a left ductus? And so again, remember, the color helps. That was how we reasoned through this case. This is going back to the SVC. This is not a right aortic arch. These planes can be so close together that the vessels can seem almost superimposed. And so slow it down, think it through, and you will realize this is not a vascular ring. And this was another first trimester case. Again, similar thing, but you can clearly see that you're picking up with this slow flow. You can pick up these tiny vessels, and sometimes if you're not used to interpreting it, you have to stop and think about it. Finally, sagittal views. We know that our ductal arch comes the most anterior underneath the sternum. We know our aortic arch is the curved with the head and neck vessels, but sometimes they are so close to each other that it becomes difficult. And the earlier you are in gestation, the closer they are together. But it's important to differentiate them. It's important to see where your IVC is, especially for cases of interrupted IVC with azygos continuation. So here was a case. This is a normal again. Here was a case where on the left-hand image, you see what is going on here. These vessels are almost merging. But in fact, it's not. If you look at the clip, you'll see that your IVC is separate from the aorta. And what you're getting is the shadow of the diaphragm here as well. So you do not want to mistake this, because this is perfectly normal, versus side-by-side vessels that have different direction of flow. And if you ever see that, I tell my team, if you see that across the room, you know immediately that this is interrupted IVC with azygos continuation, because your IVC and your aorta are far immediately from the diaphragm down, and it's not till lower in the abdomen and pelvis that they come close together. So to conclude, this is so important to optimize so we don't get positive and negative diagnoses. Know your anatomy, know what should be there, know the sonographic clues for various congenital heart defects, and think through your imaging. Remember your angle of insonation. Remember, optimize your color. Remember gestational age limitations. Remember the area below the heart. Remember the importance of establishing proper situs. Remember your left ventricle, the right ventricle, the area behind the heart, which has the most clues, and the area above the heart, and of course, your sagittal arches. And I thank my team. Remember, every little heart matters, and thank you for your attention.